That's really good. That's really good.
They are keeping me alive. Making
Yeah.
You are making us study more, madam.
No, but you are as such very hardworking person.
It's always there as an musicians.
Ma'am, we are live now, ma'am.
Yeah.
Thank you, ma'am. Good afternoon, everyone. Myself, I am Dr. Karpagambal Sairam, the chairperson of Midlife Committee of OGSSI. Cordially invite you for yet another interesting, crisp webinar on about midlife. We all know that 40 years is a very significant milestone for man and women. We know that many are having their first baby after the age of 40.
Call me later. I'm busy.
The biological clock is ticking. There has been a significant population drift towards older mothers, and age of marriage has gone up. So actually, they're all saying we should settle down. Now we have got quite a lot of issues starting at 40, which is a very important milestone. So we have an excellent webinar with experts talking about certain topics. And the age of menopause has gone up. Menopause remains static though. So now I request our president, Dr. Jairani Kamaraj, to give the welcome address. Dr. Jairani,
yeah, you need not introduce me.
No, madam. Just a few lines. Madam is a very dynamic and very vibrant president of our OGSSI, and it's really fun working with her. And Madam is really down to earth. What I like really is Madam is always enthusiastic. At this age, I think Madam is so enthusiastic. I find it difficult to keep pace with her. Over to you, ma'am.
Thank you, Kapaga, for the nice introduction. And I'm really getting energy from you youngsters. That is the secret of how we getting energy. I have the great pleasure, pride, and honor to welcome the chief guest of this webinar, Dr. Archana Verma, and the guest of honor, Dr. Anju Soni, my good friend, and all my great people in Foxy who are with us to be here, to be a part of this webinar. I welcome you, Archana ma'am, Anju ma'am, for this webinar. And I have the great pleasure and honor to invite and welcome the speakers, senior faculties, and all my great easy committee members, my secretary, and all the committee members of Midlife Committee of OGSSI for this webinar. And a very special thanks to Shield for giving this platform. And very special welcome to all the delegates also who have joined with us. Over to you, Karpaga, for the continuation of this.
Now we have the Tamil Thai Vazhuthu with a traditional prayer. Next is the lighting of the lamp. It's a virtual lighting. We'll all pray the Almighty for all well-being. Now we have OGSSI prayer. The OGSSI prayer will be rendered by our secretary, Dr. Kundavi Shankar. Madam is my teacher and my guru, and very, she taught me the first basics of fertility and everything, and even advanced ART. Madam, you can say the Oxy prayer.
Thank you, Karapagam. Thank you, God. In humility we gather. In gratitude we pray for all the good things you have given us. Shower us with your blessings to pass on the healing touch, to celebrate the arrival of each new life and a mom reborn. The courage to deal with it when things are not perfect, and to remember that we are but messengers to keep our women safe and free from sorrow. We bow before your kindness and the magnanimity of your endless love. Thank you.
Thank you, ma'am. Now I request our president, Dr. Jairani Kamaraj, ma'am, to welcome the chief guest and guest of honor and introduce them.
So respected chief guest, Dr. Archana Verma, who is the past vice president of FOXY and a very good friend of mine, who is very passionate about creating awareness in the women's health. That is her theme. That gives the energy she has about the women's health. And she was the founder president of Western Uttar Pradesh ISOP chapter, and she is the advisor of Uttar Pradesh COG, and she was the organizing chairperson of Uttar Pradesh COG on 2020, and she has a lot of awards for her. The best being the Dheera Award 2022.
That's more than enough.
Women's Health. And over to you, Archana ma'am.
Okay. Thank you. Thank you so much, Jairani. I welcome my guest of honor today with me, Dr. Anju Soni. My God, I have never seen such a great welcome, and I'm really impressed. And what a mesmerizing video of prayer and everything. I'm totally impressed. Amazing, amazing, and amazing. I like, Abhi, this is just a beginning, and I'm sure what your midlife committee is going to do. Such a energetic and active chairperson you are taking care, and all your students and your secretary. I think the wonderful work you people are doing, and you are doing again and again, and I really request to keep me again and again, even if some not as a chief guest, but as a just be with you, because it's what a great. And I'm going to take that video from you, and I would love to work with you all, and really it's a wonderful thing. And midlife committee and midlife age, Dr. Anju will be much better, will be telling you each and everything, because you never know, age is just a number. For some people it may be 30, some people it may be 40, and even it may be a 70 for few people. What is midlife? Because few people still feel young all the time, and they are energetic all the time. And so my good wishes to you and Jairani for all your future endeavors. I really, really wish that you come. We need people like you, and you will agree with me. Thank you all.
Thank you.
Thank you. Thank you so much.
Thank you, ma'am. Thank you for the nice words. And really, your words are inspirational. And we really forward that video to you. It's actually the video of our Tamil Thai Valthu, what we sing as a traditional in every events. When we start, we pray the Tamil Thai, who is the mother of Tamil goddess, to bless us for all the knowledge and the wisdom. That's the meaning of wonderful. That. So definitely, I'll forward that video to you to look into it and enjoy. Thank you, ma'am. Thank you.
I must admit, I've never seen such a elaborated prayer, and that thing. Even Oxy, I was just listening as if it is a Foxy. It's a wonderful, wonderful. Really, you're giving importance to each and everything. Thank you.
Thank you. Thank you, ma'am. Thank you so much for joining us and blessing us. So now I have the great pleasure and honor to welcome and introduce Dr. Anju Soni, who is the President-elect of IMS, very actively working for the middle life of the women folk. She has a lot of work she has done for the HIV and AIDS committee with her very best ways of encouraging very many people and all the societies she has appreciated with her work. She has given a lot of awards. She is working dynamically in the committee, and really it is a very, very much appreciated committee of the FOXY with your energetic work, Dr. Anju, and we're really proud to have you here. And Madam is the Secretary General of IMS 2022-23. She's the President-elect of IMS between 24 to 25, and we look forward for your dynamic work as a IMS President. and we all will be joining you hands for this effective work of you in IMS chapter after your completion of this HIV and AIDS committee of FOXI. And Madam is the member of the India CCM, and she has a lot of awards. A very best award is the COVID Warrior Award, which is really amazing, and the Silver Jubilee Award by the IMS, and the Chistika Vibhushan Award by the Health Minister of Government of Rajasthan. And she has a lot of appreciation awards from many of the chapters, and she had made a lot of awards of excellence in the medical field by the Betty Shrishta Ratna, organizing very many free camps for poor people over many of the cities in Jaipur. And that is a real amazing work that she's doing for the public, which is very much inspirational for many of us to work for the public, which is very much FOXI, and you are going straight into the into the society and the community to show them really what is the work that you have been doing. It's amazing, Dr. Anju. And
thank you for your kind words, Dr. Jayarani. I have seen you working very, very hard. I've seen your knowledge, the way you take your lectures, and you are a deserving person for any kind of post you require. But I've heard a lot of your lectures also, and today the program you have created by involving everybody, including as such, Indian Menopause Society is very, very close to my heart. And I feel that this is that phase of life where we are, basically, it's 1/3 of our life we are having in this period, and that is very, very important. There are many, many issues which need to be focused in that part of life we have, and it is very important for us to focus, because we are giving a lot of focus to, say, maternal care, antinatal care, and all those things. But it is really required that we give care to we really require and give care to the this part of women's life where government is not putting any kind of help. And you have created a very beautiful program, because it is now, I think it has become for every day, the fertility at 40 has come to stay with us, with girls working late, then getting married, and then settling down. Then they want to delay their fertility, and then they don't even know that what may happen to them. And so we need to make them aware by letting them know, and also the doctors. And then we all know that because of our diet and pollution, there is a lot of risk of premature ovarian deficiency. And of course, sexual health is another important thing, because if a woman does not have a good quality sexual life, then her quality of emotional, social sexual life get deteriorated. So that needs to be addressed, because as such in our country, women are shy to come out. So as a clinician, it's our job to come forward and ask them this question. And when we ask them, they do come out, and they do tell us about their problems, and we need to address it. Last year's theme was sexual health by the International Menopause Society, and it was taken into very serious consideration. So you have addressed that topic. It is a topic for every day. So my best wishes to you, and best wishes for today's webinar, as well as for all future endeavors to you. Keep working hard and keep growing. Thank you very much for inviting me.
Thank you, ma'am. Thank you, ma'am. Thank you for your nice.
And I would like to thank each and every person who is involved in this program, who call me day and night again, that madam, you have to be there. And all your speakers, I know them personally, but I don't want to delay your academic program by naming each and every one of them. From my side, I wish them good luck, and thank you for everyone.
Thank you.
Ma'am. Take over. Please take over. Yeah.
Thank you so much. Thank you, Chief Guest and Guest of Honors, and thank you, everyone. Now, I take the privilege in introducing the chairpersons for the scientific session. We have two very eminent persons. One is Dr. Asmita Mala. Dr. Asmita is a very good friend of mine. She is a reproductive medicine consultant at Asha Kiran Fertility World in Punjab, and she's a very, very enthusiastic and very dynamic person, very friendly, and it's very happy that you could join us, Smita. And next is Dr. Shubha Lakshmi Kurtukoti. She is a consultant obstetrician gynecologist at Kurtukoti Nursing Home, Pune. And Shubha and her sister are a very good friend of mine, and they are the most bubbly sisters I have ever seen. They're always full of life. And Shubha has a lot of hobbies like trekking, and she actually likes holidaying. And you see her Facebook, it's full of enthusiasm. Thank you so much, Dr. Shubha Lakshmi, for joining. Now, there's a small change in the program. Dr. Shushila has an emergency, so she is speaking first. Next will be Dr. Divyashree. So first, I request Dr. Sushila ma'am. Dr. Shushila Pinnamaneni, madam is a credentialized menopause practitioner, and she's a consultant obstetrician and gynecologist at Lata Super Specialty Hospitals, Vijayawada. And madam has actually a lot of things to her credit. She's the president of Vijayawada OBGYN Society 2022-23, secretary of Vijayawada Menopause Society, member of MTP committee of FOXY. She has organized a lot of conferences. She has got a lot of awards to her credit and authored chapters. And madam, it's one of the most important topic, POI, because when it comes to fertility, we see a lot of women who, when they start their childbearing at an older age, their ovaries have actually stopped functioning or declined in functioning. So POI is a very important factor. And over to you, Sushila ma'am.
Yeah, thank you, Dr. Karpakam. And then thank you for adjusting me also. So because I have an emergency, I didn't want it to just go without doing this talk also. And I know Dr. Achana Verma madam, under her I worked as president of Vijayawada Obstetric Society. Also Dr. Anju Soni, under her leadership, I have been working as secretary of Vijayawada Menopause Society. I know Dr. Jairani madam also met her several times. Thank you so much. And then it is indeed a privilege to talk in front of all the learned people. So thanks for the opportunity, madam. And then I shall share the screen. There's a problem. Are you able to see my screen?
We could see it, now it's not there, ma'am. It was seen earlier. When you put the slideshow, it was seen.
Now we can see it.
Yeah, now we can see. Yeah, now we can see, ma'am.
Yeah. Yeah.
Yes, ma'am. Yes, ma'am.
Yeah. So primary ovarian insufficiency, and this is a topic like last 2-3 years in several webinars, it has been discussed by many of our colleagues. But I would like to enlighten only few points that we would like to stress in our daily practice, and then which are very important. So premature ovarian insufficiency, primary ovarian insufficiency, premature ovarian failure. All these three terms are interchangeable and they are synonymous. And premature menopause is a different terminology where it is a cessation of the menstruation and the ovarian function is no more going to be there. So the other three are interchangeable. So we can use vice versa. And the diminished ovarian reserve is a different part of it. And then in the coming slides, I would discuss regarding it also in short. So primary ovarian insufficiency is defined as alteration in the menstrual pattern under 40 years of age. And then it is a hypergonadotrophic hypogonadism status in a woman less than 40 years of age. And it is a spectrum disorder and is a continuum of impaired ovarian function. And how do we diagnose it? So if the woman comes less than 40 years with oligomenorrhea or amenorrhea for more than at least like maybe it is 4 months or more than 4 months, we cannot just stamp her to be PCO seeing at her figure. So we need to do the serum FSH and estradiol. If the serum FSH is elevated more than 25 international units per liter, or if the estradiol is low, that is less than 50 picograms per ml on 2 occasions, at least 2 to 4 weeks apart, then we can stamp her as a case of primary ovarian insufficiency. So when we see the spectrum of primary ovarian insufficiency, we have to see the 4 important points. One is the serum FSH, other is the fertility, her menstrual cycle, and then AMH. Though AMH is not really needed, but we need to see in cases where they are like wanting fertility. So all these are normal and menses is regular in a normal patient, while in case of biochemical primary insufficiency, the serum FSH is elevated, fertility is reduced, menstrual cycle, though it is regular, the AMH remains low. In case of overt primary ovarian insufficiency, FSH is elevated, fertility is reduced. Here comes the abnormality of the menstrual cycle, that they become irregular or absent, and the serum AMH remains low. So overt is what we call as it is shown up. The real picture is shown up when it becomes overt primary ovarian insufficiency. So there are many classifications, but this classification is very useful. That is the occult, where it is not shown up. Occult is like microscopic. So occult primary ovarian insufficiency is when we call it as diminished ovarian reserve. The values are normal, but the woman remains subfertile. Then comes the biochemical primary ovarian insufficiency, where only biochemical parameters change. Overt is when the menstrual cycle pattern changes, and premature ovarian failure, most of the ovaries function has decreased, but the patient can become pregnant, though the biochemical parameters are changed. And premature menopause is where there is complete cessation or depletion of the primordial follicles, and no more your ovary can function. But what we need to remember is, in the primary ovarian insufficiency, there is intermittent ovulation, there is intermittent hormonal release. That is why the fertility can take place. That is why there are irregular cycles in these patients. So the incidence increases with age. At 20 years, it is 1 in 1,000. At 40 years, it is 1 in 100. And what is the mechanism of the primary ovarian insufficiency? It is mainly because of the follicle defect, developmental defect, that is the low primordial count at the birth, or destruction, that is the follicular atresia. Maybe it is due to the dysfunction of the follicles, that is, there is an accelerated destruction, and the quality of the follicles is not good, where there is a dysfunction of the follicle, and disorders, that is the genetic disorders. So in all these cases, we see the primary ovarian insufficiency. There are 3 Ds, that is the developmental disorder, destruction, dysfunction, and the disorder, genetic disorders. So most of the time, coming to the causes, most of the times it is idiopathic. That is 70%, we do not know why the patient has gone into the ovarian insufficiency. In some cases, when we investigate, we see the genetic problems like Turner's and Fragile X syndrome, autoimmune polyglandular syndromes, etc. And sometimes we see even the autoimmune disorders are also the causing factor of the primary ovarian insufficiency. And in some cases like tuberculosis, malaria, mumps also, where there is an acute amenorrhea, and we see that the FSH is elevated and the E2 levels are very low. In these cases, because of the infections, there is primary ovarian failure. And induced or the iatrogenic or the bilateral oophorectomies, ovarian cystectomies, and chemotherapies where the alkylating agents are used, or the radiation, and pelvic vessel embolization, environmental toxins, which has to be taken into account definitely, the plastics and all these cause premature ovarian insufficiencies. And other important thing is, as we are in the COVID era, and we know all in the COVID, there are microthrombi formed, which has created a havoc of the black fungus and etc. So this microthrombi can also may lead to primary ovarian insufficiency in the coming days. So the chemotherapeutic agents, we all know they are gonadotoxic, and also they cause ovarian insufficiency, maybe it is for a shorter time or maybe it is permanent. So the most common is the procarbazine, where it is used almost the ovary goes into a zero functioning. And radiation doses are different at different ages where the ovaries get damaged. It is around 20 grays at birth, while it is at 60 grays at the age of 40. So repeated dental, the repeated CT scans, etc., have to be avoided unless otherwise, which are very commonly used nowadays, CT imagings and all, radiations. And clinical presentation is usually menstrual abnormalities, primary amenorrhea or sudden onset of secondary amenorrhea, subfertility, menstrual symptoms like hot flashes, where it is an overt premature ovarian insufficiency. We see patients do come with vaginal dryness, hot flashes, sleep disturbances, and changes in skin pigmentations in the case of the adrenal tumors, vitiligo, which is an autoimmune disorder, hyperpigmentation, that is adrenal insufficiency, hair loss, alopecia in autoimmune disorders, goiter and thyroid problems, fatigue and anxiety, depression. All these are maybe the clinical presentations. This is an important slide. So we get some of the women who have come with a history of normal puberty, followed by that they have normal regular cycles, and suddenly there is a disturbance in the menstrual pattern. This is one presentation. Other presentation would be they develop sudden amenorrhea, that is acute amenorrhea, or experience a prolonged prodrome of oligomenorrhea. This is the second presentation. The third presentation is following OCPs or after the delivery, they don't get cycles. So all the problems of hot flashes and all are managed by the oral contraceptives, and she doesn't say any symptoms of hot flashes or any dryness because of the estrogen and progesterone contraceptives. But she does not get a cycle for the next 6 months, then we have to evaluate the serum FSH and the estradiol levels. So we need to ask about the history, if there is any family history, medical history, or about the any family history of POI in the first or second degree relatives, recurrent pregnancy loss in their relatives, and any symptoms of fatigue, weight fluctuations, and physical examination has to be done. And again, I reiterate, if the patient is obese, we cannot just chamfer as PCO and then not to do any investigations is a blunder. We do have to do investigations and then decide upon whether she is a case of POI. And the laboratory test to exclude pregnancy is the serum beta HCG and follicular stimulating hormone estradiol, and anti-Mullerian hormone to assess ovarian reserve. This is only in case she wants a fertility treatment. And karyotyping to know the genetic etiology, thyroid stimulating hormones, 21 hydroxylase antibodies. And 21 hydroxylase antibodies, if they are present, it is going to cause premature ovarian failure. And a radiological test like transvaginal ultrasound is also important for the ovarian reserve and antral follicular count. And to evaluate the bone density, DEXA may be used, and also to start the treatment and to find out if any secondary causes of decreased bone mineral density. So it's always important, only the biochemical parameters are important, but pelvic ultrasound is not really needed for diagnosis. But if we see a thin endometrium and bald ovaries. So again, this slide is very important. When a woman comes with, this is for our practice. So when a woman comes less than 40 years with irregular menses, negative serum beta HCG, and comes with a history of hot flashes, we need to measure the thyroid hormone TSH, prolactin, FSH, and estradiol levels. If the estradiol levels are low, along with serum FSH, it is hypogonadotrophic hypogonadism. If the serum FSH is high and low E2, it is POI. Suppose if the serum FSH is high, but estradiol is also high, then we have to repeat the serum FSH on day 2, because it is because of the mid-cycle surge, and then diagnose as if again it comes as high FSH and high E2, we need to stamper as query pituitary adenoma. And the sequelae, we all know it is reduced fertility, cardiovascular problems, genitourinary symptoms, decreased BMD, leading to fracture risk, poor quality of life, all of these leading to high mortality rates. So how do we manage a case of premature ovarian insufficiency? Mainly, we need to manage the menopausal symptoms, cardiovascular health, bone health, emotional health, infertility, and cognition. And the focal symptoms like dyspareunia can be managed with the local estrogen, testosterone for libido. And cardiovascular health is usually, there is an increased formation of atherosclerotic plaques leading to the cardiovascular morbidity and stroke. So we need to replace the estrogen. We all know that bone health is directly proportional to the estrogen level. So we have to start her on the estrogen for preventing the fractures and also increasing the quality of life. Apart from that, we need to ask her to have the lifestyle modifications like weight-bearing exercises, dietary calcium, vitamin D, avoidance of the cigarettes, which decrease the bone quality. And the cognition, we all know that earlier the surgical or the POI, there is a decrease in cognition. So in case if she has other problems, also we need to replace on the estrogen. And these patients are emotionally very liable. So we need to support them, and multidisciplinary team is required. Premature aging, reduced self-esteem, social anxiety have to be tackled by the psychological counseling. And infertility, my next speaker is going to talk about it, but only issue I would like to stress upon is the chromosomal aberrations, and then the genetic disorders have to be ruled out, because they may have the genetic disorders and this can pass on to the next generation, and we need to prevent or minimize the next generation to the transmission to next generation. And the hormonal treatment is needed in the premature ovarian menopause for the better health and quality of life. So the estrogen has to be replaced and serum estrogen has to be maintained at 100 picograms per ml up till the age of 51. So there are two aspects. One is the post-pubertal premature ovarian insufficiency, other is a pre-pubertal. In the post-pubertal, if she is hysterectomized, we need to just supplement the estrogen either in the form of the estradiol 1 or 2 milligrams or the conjugated estrogen of 0.625. And the dose and other regimes are well known to everybody, so I'm not going to talk about it. And the progesterone has to be supplemented if the uterus is intact. And the estrogen has to be, the endometrium has to be protected by the progesterone. And coming to the pre-pubertal premenopause ovarian insufficiency. So this is mainly for the health of the adolescent. This usually is we see in the adolescent age group. So we need to start her on the serum beta estradiol, and it is gradually increased every 3 to 6 months over the course of 2 years. That is, we start at 1 milligram and gradually increase every 6 months and until the spontaneous menses starts. After that, we need to add the cyclical progesterones, 12 to 14 days, 100 to 200 milligrams of micronized progesterone has to be started. And once the menses or the menstrual cycle is set in, then we can shift to the OCPs also. So at 12 to 13 years, if the serum FSH is elevated and she does not have her menses, we start her on the estrogen and then gradually increase up till 15 years of age and then switch on to the OCPs. So HTA guidelines are there, and regarding the management of women, the premature ovarian insufficiency, and this is a very good paper and we can all go through regarding the treatment. And what are the risks of HRT? And we all know that there is no increase in the breast cancer. Best option would be the 17 beta estradiol. And after we start also the 17 beta estradiol or progesterone in a patient with premature ovarian insufficiency, there is nothing like we need to follow every year unless we suspect any problem. Otherwise, we can just go ahead and give her up to 51 years. So there is no need of monitoring. If androgens are started, we cannot usually use more than 24 months. This is mainly to increase the libido. And Turner syndromes, we have to offer HRT throughout the normal reproductive lifespan. And if the patient has a BRCA gene mutation, we cannot give the hormones to her. And endometriosis, we need to supplement with progesterone. And in case of migraine patients, it is a contraindication to give estrogen or the plus progesterone. So mainly the hormonal therapy decreases the vasomotor symptoms in the POI suffering patients Genitourinary symptoms, bone health is improved. Cardiovascular health also gets improved. Sexual health, definitely to say yes. And life expectancy, it is an indirect benefit to the woman, and also the quality of life improves. Definitely cognition and the neurological function improves with the estrogen and the progesterone, which are to be there for premature ovarian insufficiency. So the key points are: suspect primary ovarian insufficiency in women with unexplained menstrual abnormalities, infertility, or symptoms of estrogen deficiency like hot flashes and vaginal dryness. Confirm the diagnosis by measuring the FSH. It is usually more than 25 and estradiol is low, less than 50 picograms per ml. And measure the anti-Mullerian hormone if she wants to go for a fertility treatment. And in case of an autoimmune cause is identified, the treatment has to be for the autoimmune disorder also, plus the POI. And unless contraindicated, estrogen and progesterone has to be prescribed for the improving the quality of life of the patient and to relieve the symptoms and complications of estrogen deficiency. Thank you so much. Thank you, madam, for giving me this opportunity. Thank you so much.
Thank you, madam. That was a very amazing presentation that you made for the POI. Put everything in a nutshell about all the aspects of the POI, which is really a very good presentation. Thank you, ma'am. Thank you for being with us in midst of your emergency, joining us and giving your lot of inputs about the POI.
Thank you so much.
Over to the chairpersons.
Chairpersons, Dr. Asmita and Dr. Shubha Lakshmi.
Hello.
Yeah, we can hear you. Yeah.
Thank you, Dr. Jairaj and Karpagam, a real good friend of mine. And madam, you've given a very crisp presentation regarding a very important thing that we are facing day in and day out these days. Premature ovarian insufficiency is coming up in such a huge way that we have to really deal it in a very delicate manner. The way you told that it has involved a social aspect to it, an emotional aspect to it, and the reproductive angle is also attached, because women are seeking fertility at a very late age now. Having a comprehensive approach and a multidisciplinary treatment and telling them what are the implications of the therapies and the things that can change the quality of life of these women is really needed. Thank you for the presentation. That is giving a lot of information to us also as practitioners, madam. Thank you.
Thank you so much.
Thank you, ma'am. Thank you so much. Now we'll go more to the next speaker, Dr. P.S. Divyashree. Dr. Divyashree is also a very good friend of mine. She is a very dynamic, we call her a nerd, always studying and always, everything is in a walking encyclopedia. Divyashree is a medical director of Genia Fertility Center. She is secretary of IFS Karnataka chapter, and she has got a lot of awards to her credit. And what I can say about Divyashree, she's a walking encyclopedia and she knows everything about ART and obstetrics and gynecology. Over to you, Divyashree. Dr. Divyashree?
Can you hear?
Yeah, we can hear you. You can share your screen.
Yeah. Thank you for the kind introduction, Karpagam.
Thank you.
It's too nostalgic for me to, see you and Asmita here. I'm just going to the nostalgic days of Chennai days.
Yes.
Of fellowship.
Yes.
So nice to see you both. Just give me 1 minute time. Please give me 1 minute time.
So as we all know, fertility is always at 40 is a big question mark. 40 is a very important milestone, as we said. So Divyashree is going to enlighten us about what are the issues of fertility at 40.
Got it, yeah. Yeah, I'll start sharing my screen.
Yes, please.
Dr. Karbakam, can I leave, madam?
Thank you so much, madam.
Yeah.
Thank you, madam.
Yeah, yeah.
Thank
So
you,
there's
madam.
an emergency, please. Yeah.
I know. We
Yeah.
understand,
Thank
ma'am.
you. Thank you so
Thank you
much.
so much. In spite of it, you have come
Yeah.
back and
Yeah.
given
Yeah.
us the presentation. Thank you, ma'am.
Thank you
so much. Thank you.
Is my screen visible?
Yes. Its PowerPoint is opening the visual.
Yeah. Some problem with this. That's why it was just taking time. What should happen directly with this? Yeah, is it visible?
Yes.
Yeah, as you have rightly put the foundation for me, fertility at 40 is something which is quite challenging for all of us fertility specialists, and this is not very uncommon, and we have all been seeing patients at 40 now. An overview of today's presentation is on why fertility is a concern when we are at 40. What are the modalities that are available to treat these men at 40 is what I'm going to talk to you all. So as we know, age is undoubtedly the most important predictor of a woman's fertility. With more and more couples postponing pregnancy due to career ambitions and late marriages, a knowledge of age-related decline in fertility, especially among women, is very essential. As we know about ovarian folliculogenesis, little bit of basics. We know that there is initial recruitment and also cyclic recruitment. Initial recruitment is not dependent on anything, whereas cyclic recruitment is dependent on gonadotropins. The depletion of follicular pool is not just when we are at 40. It begins even when we are all women, we are all as embryos in our mother's womb. At 3 to 4 weeks, primordial germ cells, they migrate from the endoderm of yolk sac to the primitive gonads. At 5 to 6 weeks, it's around 10,000, and it is maximum at 20 weeks, where mitosis, meiosis, and atresia all are going on together at 6 to 7, and the amount is approximately 6 to 7 million. And at birth, it is approximately 1 to 2 million. And during puberty, it is just 3 to 5 lakhs. And a woman would utilize 400 to 500 of these 3 to 5 lakh oocytes during her reproductive lifespan. Even at 37 years, a woman's follicular pool is at 25,000, and at menopause, approximately 1,000 follicle. But how far they are functional is what we don't know. We all know with increasing age, there is decrease in quantity, not just quantity, but quality of oocytes. As you see, even though women attain menopause, especially Indian women attain menopause at an average age of 45, but the decline in fertility begins much earlier. So every woman's fertility is at its peak when she's in her 20s, but it starts decreasing when she touches 30. And the decline in fertility is very drastic when she's 35 and above. After 40, it is very minimal, and after 45, it is almost nil. As you can see, even menopause is at around 50, but the decline in fertility begins much earlier. So it is very much prior to the onset of menopause, despite of having continued regular ovulatory cycles. Our patients do tell us, I'm perfectly healthy, my periods are regular, but how do you say my fertility has declined? This is what we have to tell them. And this is not just about our experience. It is also proven with studies, and the statistics says 6% at the age of 20 to 40 would remain childless if they don't use contraception. And it goes up to 64% when she's at 40 to 44. what are the theories of origin of ovarian aging? We have come across so many things. There's not just ovarian aging. We also know about the cardiovascular aging. We also know about the cardiovascular health, and also many other aging factors with all the organs. So also ovarian aging is an important milestone that we have to understand as reproductive medicine specialists. Ovary itself is one of the theory, because as the number of follicles decline, there is reduced inhibin. Secondly, the FSH rises, and AMH is like a gatekeeper. I always tell my students, AMH is like a gatekeeper. It actually checks the follicles from recruitment, but as the follicles decreases, the AMH levels come down because it is produced by the primordial pool of follicles. And as the AMH is decreasing, ovary will have loss of inhibition from recruitment. That's why more and more follicles get recruited. And apart from this, there is dysregulation of hypothalamo-pituitary ovarian axis, which could also result in ovulatory dysfunction. And also, it is not just about the overall pathway, it is also about the oocyte quality, because as a woman ages, the meiotic spindle abnormalities set in, which could be in terms of chromosome alignment, microtubular matrix, even single chromatid abnormalities would increase, thus resulting in aneuploidy. And this is just a statistic for us to understand. This is in Fertility Sterility 2022 April issue, where what is this about biological versus chronological aging? How does quantity and quality decrease with aging? If a woman at 35 years, if the percentage of aneuploidy is approximately 10%, at the age of 40 years, it is 30%, and the age of 43, it is 50. And remember, at the age of 45, the aneuploidy rate is almost 100%. So if, as specialists, if somebody asks us, when do you say absolute no for own eggs, it is approximately at 45, because we know with statistics that the euploidy rate is almost zero, or the aneuploidy is almost 100%. So beyond 45, it is futile exercise for us to counsel a patient or to tell a patient to go through an IVF. But the problem is squeezing birth into working life. We can't run away from this problem. We can't tell them, okay, you should get married early. But how do we squeeze this birth into working life? So that is how we have to face these challenges in present day couples who are postponing their pregnancy. So postponing childbearing reduced completed fertility rates. It's not just about achieving age-related female fertility decay. So how to predict ovarian reserve? That is what we should begin with. So if we have to say, okay, how do we deal with? So let us understand how to diagnose this problem. So we all know the 3 A's, that is age, AMH, and antral follicle count. So there are various markers for ovarian reserve, out of which there are clinical markers, sonographic markers, and endocrine markers. Clinical markers, I told you about age, menstrual pattern. Sonographic markers are antral follicle count, which is the one which is most commonly used. Endocrine markers, there are statistic and dynamic markers, but we most commonly use AMH. These are all for postgraduates who are attending this. If a question comes on ovarian reserve, you have to depict this flow chart. But for practical reasons, as I told you, 3 A's, age, AMH, and antral follicle count is good enough. Why anti-Mullerian hormone is good? Because it is produced by preantral and small antral follicles, so it's a direct indication for ovarian reserve. It's a dimeric glycoprotein, small antral follicles related to size of primordial follicle pole. It can be measured on any day of the cycle, no intercycle variability. And what is the level that we take as a cutoff for poor responder is between 0.2 to 1.26. Among these multi-markers, AMH is the best predictor of all. Enough and more studies are there to prove this fact that AMH is a very good predictor of ovarian reserve. Also, we have to understand with reproductive aging, pregnancy rates would decrease. It's not just with natural conception, so also with IUI. Pregnancy rates in women undergoing IUI with donor sperm, where the male parameters have been ruled out. If the pregnancy rate was 74% for women younger than 31, it would decline to 62% in women between 31 to 35, and approximately 54% of women older than 35. Not just for IUI, even with IVF, you can see there is gradual decline in fertility with increasing age. So it is not just about achieving pregnancy. So after pregnancy, what are the complications? After 35, frequency of aneuploidies are more. So there are more chances that we may find an abnormal fetus during the anomaly scan or even at NT scan, so resulting in abortions. Or also, roughly 50 to 70% of mature oocytes from 40-year-old women have chromosomal abnormalities. There is increased risk of leiomyomas, tubal disease, and endometriosis. There is also high risk of GDM, preeclampsia, low birth weight, sudden IUDs, and even operative deliveries. So, according to the committee recommendations way back in 2014 regarding female age-related fertility decline, the education and enhanced awareness of the effect of age on fertility is essential in counseling the patient who desires pregnancy. Women older than 35 years should receive expedited evaluation and treatment after 6 months of failed attempts to conceive or earlier if clinically indicated. Even when we define infertility, it is not always more than 1 year. We have to always categorize them, especially if a woman is more than 35. The infertility definition does not hold good for 1 year. It could be even just 6 months where we have to initiate evaluation in these women. And in women older than 40, immediate evaluation is indicated. It is not just about aging women, it is also aging men. Obviously, aged women will marry aged men. So in these men also, there could be age-related decline in testicular function. Seven parameters do get affected. There is increase in DFI of sperm. And in men who are more than 40, there is also studies showing there is increased risk of spontaneous abortion. Frequency of Down syndrome is higher, especially autosomal dominant disorders like achondroplasia, neurofibromatosis, autism, and schizophrenia is found to be higher. Even imprinting disorders like Prader-Willi syndrome, Beckwith-Wiedemann syndrome, they are all higher in men who are of advanced paternal age. So it is a combination. It is like, double dhamaka of aged women with aged men or advanced age hits both. So now, how to reverse this age-related decline? Now that we have understood the gravity of the situation, and it is not very uncommon for us to see, we have to manage these patients. First, we have understood how do we investigate them. Basically, we always see what is the reserve in this particular woman who is at 40. If she's at 40 and the reserve is good, we still have better probabilities because every egg in the kitty counts, whether it is chromosomally normal or abnormal, but the egg numbers do matter. So can we reverse this at any point of time? So which is mainly act before, during, or after recruitment phase. If we can intervene in this natural aging, where do we intervene? If at all it is before, that is at growth phase, or is it during stimulation or around the time of recruitment or after recruitment? How do we manage this? There are various treatment options which are available. There are various protocols which are available. I'm not going into the details of these protocols. It could be microdose, antagonist, agonist protocols, or it could be even hatching of embryos. Estrogen or oral contraceptive pre-treatment, there are again various controversies to this, whether oral contraceptives should be used or not. Now it is more or less oral contraceptives should not be used. Probably pre-treatment with estrogen is a better option. Pre-implantation genetic testing. Again, there are various pros and cons for this. Do we have to use or not to use? Oocyte vitrification, mitochondrial transfer, and ultimately oocyte donation. Coming to pre-treatment, we do use a lot of pre-treatment, especially in terms of testosterone. So the tree transport trial is still awaited. I mean, it's almost awaited from 2 years now. We have still not got the outcome of this trial. DHEA is supposed to be helpful. Even using recombinant LH HCG during stimulation, and also the kind of protocol, whether antagonist protocol is better or agonist, pre-treatment with estrogen, and coenzyme Q, which is a mitochondrial enzyme booster, which is catalyst for ATP. Whether that is going to improve the oocyte quality is one thing which we still have to prove with many more studies. There was a Chinese study in which coenzyme Q was really helpful in when it was tested in different categories of Poseidon criteria 1, 2, 3, 4. It was helpful in Poseidon group 3, but Poseidon group 3 is women who are younger. So that is why the query started again that if it could help in a woman who is younger, we are not looking at it. Anyway, the mitochondrial function will be good in a woman who is younger. So is it really going to help in poor responders, especially of advanced maternal age, is what is a question which still needs to be answered. So in 2020, Zhang et al. Concluded that DHEA, coenzyme Q, and growth hormone were the top 3 agents that improve the probability of achieving pregnancy, and these treatments also had lower cycle cancellation rates in patients with poor ovarian response, although live birth was not primary outcome measure. We have heard about DHEA and coenzyme Q, I told you already, but when it comes to growth hormone, previously there were 3 meta-analyses, and all these meta-analyses, there were only 2 or 3 studies, and every meta-analysis showed that yes, it is helpful. But in 2022, again, there was a meta-analysis where this time there were almost 8 studies which were included, and growth hormone was supposed to be helpful in improving the cleavage rate of embryos in these women with advanced maternal age. Whether it is going to improve the live birth rate or not, we still don't know. So growth hormone could be an option in women who have had previous IVFs, but there was poor cleavage rates. Probably growth hormone could help according to the latest meta-analysis. Role of dual trigger. Why do we have to trigger them twice, or why do we have to use 2 triggers? Could be because, as I told you before, the altered hypothalamo-pituitary ovarian axis. So double the better is probably the hypothesis behind this, because HCG acts at the level of directly on the LH receptors, but GnRH agonist acts at the level of hypothalamus, pituitary, and then ovary. And GnRH agonist trigger when we give, there is a small amount of FSH surge, which is equally important in women who are of advanced maternal age, because this FSH surge is important for the cumulus expansion and also for the cumulus function, and also the cytoplasmic maturation of the oocyte. So probably dual trigger could be of help. Then dual stimulation or embryo pooling. The embryo pooling is an entity where we keep on pooling these oocytes. If you ask me, why do we have to pool them? Here, embryo pooling is important for us to have a good cumulative pregnancy rate. As infertility specialists, we don't want to fail, right? So when we look at cumulative pregnancy rate, the probabilities are any day better rather than having one embryo transfer and then having a failure. So that is one thing. And the second thing is, if a woman conceives in the first attempt, say it is just one oocyte, one embryo, she conceived. But what happens when she has to plan for a second pregnancy? So embryo pooling also is important modality as a fertility preservation. Then coming to dual stimulation, embryo pooling can be done either as a single cycle, starting from the follicular phase, ending in the mid follicular phase, then again starting in the next follicular phase. Or it can be in the follicular phase stimulation followed by luteal phase stimulation as well. So given the difficulty in collecting enough oocytes in a single round of stimulation, accumulation strategy could represent a valuable approach, especially in women with advanced reproductive age and reduced ovarian reserve. It is not that dual stimulation would help or it would work in every woman who is above 40. It could probably help in those women who have had asynchrony of follicles, but they have decently good reserve. They have had a pickup, but post pickup, when you see them and there are small follicles which are intermediate, or few follicles which have just started recruitment with the effect of internal E2 or with the effect of high dose of FSH, those are the ones in whom you can target, not in women who have had just the corpus luteal cyst and there are no antral follicles or intermediate follicles. Those are not the candidates to have a dual stimulation. This is a practical approach towards dual stimulation. Should PGS be done for all IVF cycles in women above 40? See, you have to understand there is not a baby in every batch of eggs. We have to understand. So with the use of PGS in this group of patients, there is a very clear possibility that we may damage or discard the one embryo that did not have the baby in it. True, but is it that it is going to improve the probability of pregnancy? No. Only thing is it could improve the time to pregnancy. For example, if we have done embryo pooling, we have got 10 embryos and it is just the 10th embryo which was euploid and I'm going to achieve pregnancy after 10 cycles. If I do a PGT, especially PGTA, I would go directly select the 10th embryo and decrease the time to pregnancy. But however, you also have to understand whether the PGT, which we do, especially invasive PGT, is it going to affect the embryo implantation potential is what we still don't know. And non-invasive PGT, yes, we also do, but is it really helpful in terms of reflection of the results and also in terms of the reporting pattern? We are still naive in this non-invasive PGT. Many more studies have to be done. So it is not just about transferring a euploid embryo. Even if despite transferring euploid embryo, what is the probability of pregnancy? There are various studies, especially in March 2023, depicting women who are categorized into two groups, less than 35, more than 35. And the conclusion of this study was increasing maternal age is associated with a decline in ART success rates independently from embryo-ploidy. So this message contributes to an appropriate patient counseling before starting PGTA procedures. So we cannot promise them sun and moon, and then we can't give them false assurances saying that just because we do PGTA, we are going to select the best probable embryo and that will give you pregnancy. So we have to be really wary about the counseling strategies in these women, especially when we are offering PGTA. Mitochondrial transfer techniques. Yeah, there are various methods to do this. One is pronuclear transfer. It's very simple. Means to explain, probably not practically. Here, the pronucleus is taken from a fertilized egg. Then the pronucleus is transferred to a healthy egg, a woman who's of lesser age, wherein the nucleus is taken off. So that is how it is done, to keep it simple. Mitochondrial transfer techniques could be spindle transfer, or plasmic transfer, and even a blastocyst transfer, where blastomere transfer involves transplantation of a blastomere from an affected embryo into an enucleated healthy donor oocytes. But however, you have to understand these are all experimental. It is not into therapeutics. But this is the reality. Diana Heaton, at 49, she decided to freeze her eggs and gave birth to her daughter, Arya. So one thing is reproductive aging is a reality. Young adults, especially 20 to 35, should be counseled about reproductive aging. At least they should be given the information. Decision is theirs. Always, as specialists, we do understand the shortcomings of all these procedures, but people should not be deprived of giving the information. They should know that there's something called reproductive aging. They should also be made to understand the medical, social, and economic implications associated with delayed childbearing. Management strategies are available but are expensive, time-consuming, and with doubtful results. So in earlier days, early marriages in 20s, childbirth by 30 is the best option, especially in these days of increasing number of young women with poor ovarian reserve. Yes, day before yesterday, I saw a patient in outskirts. She was just 19, married for 8 months, not able to conceive. Just as a routine, when we did the scan, her antral follicle count was very less. When we did her AMH, it is just 0.2. But it is not that, it is a trend. But yes, poor ovarian reserve is a hard-hitting fact, not just in advanced maternal age, but also in women who are young, who are relatively young. More and more women, Indian or otherwise, are enjoying their financial independence and are motivated to push frontiers in whichever field they choose to, thereby ignoring the fact that biological aging is taking place, maybe even faster than chronological aging. Hence, women need to be counseled at very early, at every stage regarding their fertility and options available to them. So counseling is our bit, decision is theirs. Thank you. I'm happy to take any questions either at the end of the session or probably now.
Thank you so much. Diveshi, can you please switch on your video?
Oh, I didn't switch on my video all this while.
I didn't want to disturb you during the session. Switch on your video.
Is it?
We can all see you. And then over to chairpersons, Asmita and Dr. Shubhalakshmi.
Thank you, Dr. Devashi, for this presentation, which has put light on every question that we face in the OPD regarding fertility and ART2. So thank you very much for that presentation. It was a wonderful presentation.
So
thank you, Doctor.
Diveshi, that was very nice. I just want to add up, yes, you're right. People are taking up careers and delaying their fertility. But as you rightly said, there are some women, even at the younger age, who have, who have a poor reserve without any family history, with a history of good fertility in the family. But mainly because, especially in the villages, we come across a lot of people having a low reserve, mainly due to the environmental pollutants. These are the endocrine disruptors, especially when the people working in the fields, in the agricultural farms, where they're exposed to the pesticides and the fertilizers, have a real problem for them to face through because of this reserve getting lowered by the exposure to the chemicals and the pesticides. So it's
I totally agree with you, madam, because environmental endocrine disruptors is something which is like, in thing now. And you told about pesticides, very true. But apart from that, in women who are of rural areas, they go for cheap junk. So that is also something. And also for this poultry products who are, which is artificially fed with estrogens, or estrogen injections are given for these poultry. And it is all loaded with estrogen. That is also one of the things which causes endometriosis endometriosis and per se for ovarian reserve. And also urban areas, I have seen so many college students, young girls who are into smoking. So smoking is something which is again causing decline in ovarian reserve. And also the junk, they go for costlier junk. And the end of environmental endocrine disruptors, be it in terms of bisphenols or many more, 30 dozens, they are all going to affect ovarian reserve. We also find this Mullerian anomalies of late. If you, ma'am, you could enlighten us, like, in your days of practice, early practice, how was the Mullerian anomaly incidence, and now how is it? Young girls who are just attained menarche, they come with Mullerian abnormalities. Probably these mothers who are, when they were in utero, they were exposed to this endocrine disruptors, and that's how Mullerian anomalies are also high.
Maybe that is also one thing. We don't know about the data, but one thing, they're aware of the treatment and they're coming forward for the treatment. Earlier, they were not having any access for the treatment. They were not aware of the treatment available. And the primary amenorrhea, many a times it is missed in the field. I mean, in the society, they have been put on the back door. They don't have any life at all. So that was the earlier stage. But nowadays, after the education, empowerment, and all the awareness, what we created through media and everywhere, people come out, the problems might come out. So we don't know exactly what the data, but definitely the occupation and the environmental pollutants have a great target on the women's as well as the men's fertility, which is no way doubt, because when you look at the men's semen parameters, every year 1% of the semen parameters comes down. That was the global data is given. So if you look into another 100 years, you will be losing 100% of the semen, and everybody will not have a semen at all, sperm at all. That was the outlook of the global data. So it's real challenge that we all should take some responsibilities to see this junk food, environmental pollutants, all these things. Go back to.
We are going more of seedless, madam, seedless grapes, so seedless watermelon, so seedless men and women, probably.
Yeah. That's it. Yeah.
Yeah. Thank you so much.
Somehow my video is not getting switched on.
Yeah,
So
you have to on it on. It's across. Your video is off.
No, actually I started my video, but somehow it's not opening.
No, you have to put your camera maybe in your screen, in your
settings.
Yeah.
Probably.
Camera on. Allow. You have to say that allow.
Okay.
It was an awesome presentation, I must say, and it is so nostalgic to be with my Chennai people again. I really wish to see you in person now.
Yeah, you should make a visit to
Chennai, Asmita.
Bangalore or Chennai. We should all catch up. Even Madam Dr. Kundavi is also here.
Yes.
Anyway.
Hi, Divya.
Hi, ma'am.
Nice to see all my young girls together, all big people now.
All your blessings, ma'am.
All your blessings. We've all learned the basics and advanced from
I know.
Thank you so much, Divishri ma'am.
Thank you.
Now we'll go to the next talk. It's most important thing, because nowadays we talked about fertility, everything. Now it's sexuality. That's the real thing, because a lot of people are coming with the inability to perform, both men and women. Now we have our OGSSI president, Dr. Jairani Kamaraj ma'am, who is an expert in this specialty, and madam is going to highlight all aspects of the sexual dysfunction at 40. The topic is sexuality at 40. Over to you, ma'am.
Thank you, Kapaha. Thank you for the nice introduction, and thank you for organizing this wonderful webinar, which is a real important, thought-provoking for all the women at 40, that we should be aware of the sexualities, what is happening to them in this age. Though we say that the midlife starts at 40, so many a times we have to think of what to do about their fertility we are talking, but we have to think of a very important one is the sexuality. So we all know the WHO defines the sexual health is a state of physical, mental, psychological, social well-being related to sexuality, and it is not merely an absence of disease or dysfunction or infirmity. And very interestingly, we should know what is sexuality. It is actually one which is experienced, expressed in thoughts, fantasies, desire, beliefs, attitudes, values, behavior, practices, and all the relationships and romance. Everything comes into sexuality as a gender. Everything plays a role. So the sexuality is include of all the dimensions, and it is always, many a times we may not experience many of them, though we may want to experience and express, sometimes it may not be possible. So a sexuality is something what we think, dream, dance, every aspect of each day life of a gender is a sexuality. That's what a simple way you feel about the sexuality. So this sexuality, how it's being important, the sexual health is how it's important in an elderly, especially when you're reaching 40 and above, reaching a perimenopause and menopause. What is its role? Because we all know pretty well, we were talking about the fertility. We know sex is very important for the reproduction, but there are very many things which goes beyond reproduction related to the sexual health. When you look into the benefits of sex, what are the health benefits of this sexual sex? What we see is a lot of things are coming out, both in the data as well as in the research as well as the studies, because so far till now we don't have much studies, but of late there are a lot of studies which are coming out saying the health benefits of sex. So what they say is it indicates a psychological well-being. When you have a good sexual health, that is always a well-being both psychologically, and also an active sex life can increase the longevity among the elderly. So it serves many purposes which is not related to reproduction alone, but many things in the relationship, intimacy, the way you express your love, provide a feeling of security and sharing of feelings among the partners, and also make your mind calm, and it causes a de-stressing effect by endorphins, and also have a improvement in the boosting of the self-confidence, mainly by improving your image and your self-esteem. And it also has a role of taking nearly a calories, because we all know that you people are all good in sports and exercise, but this also has a very important way of burning out some calories. They say the good sex nearly burns around 200 to 250 calories. That is a very big amount of an exercise, and it improves the circulation and improves the immunity, mainly causing a lot of endorphins to come into the blood flow. So definitely sex have a lot of health benefits, which is very important from the point of an aging people, both in the men and the women. This is a very important role it plays in the everyday life of the couple. So when you look into the aging, so we may have a lot of doubts and doubts when the sex stops, at what age, at what age the couple becomes sexually inactive, or when they stop their sexual activity. That's what the big question. And even now there are very limited research, very limited study, but still what we say is the reproduction in the sex has a limit, or it has a maximum age, but sexual activity can be experienced and preferred well into later years of age too. So we have to think that sex always runs till the last day of the women's life. And as pointed out by the guest of honor and the chief guest, that the menstruation now goes up to 51. The average age of the menopause is roughly around 48 to 48 to 51. And the life expectancy, even in the developed country for the women, is around 70 years. We all know that 1/3 of our life being in the menopausal age. So definitely the menopausal age, you have to think of the very important act, that the sex, which is a very important role that we have to consider, because the women starts her midlife at 40. By that time she enters into the perimenopause, because the physiological changes happens. It won't stop in a woman, though we stop our increase our life expectancy, improve our quality of life, but still all the physiological changes, they never change. That's what we come across, a lot of POI, lot of POF, everything that happens, a lot of impact on the endocrinological and the physiological aspects of the women's life, leading on to a lot of issues in the perimenopause and getting into menopause and post-menopause. That has a major brunt on the sexuality of the women. So when you look into the aging changes, what it really brings such a transition, which can bring a lot of changes in the opportunities for the older adults to redefine their sexuality and intimacy. And that is a very important thing that we have to understand, because a latest study in the Times of India has given that increases their improvement in the quality of the sexual act. That's what they've given, because they have more time, more privacy, less commitments, and more of a loneliness. All these things make them more go for a better quality of sexual life as they get older. And even some older adults strive for a sexual and intimate relationship, which it is a very important aspect they come through when they get older. So we all know the full expression of sexuality is dependent on the biological, psychological, and the social factors. And that is a very important, all these aspects are modulated by the very important hormone, the testosterone. So when a woman get her menopausal or the perimenopausal, this hormone is a very important one which plays a role in her sexuality. So as the expectancy and the quality of life has to be taken account in the women's, menopausal stage, we have to think of how we are going to look into the women's sexuality, which is an important emerging concern or a concern for the medical field also. Because we all know there are a lot of issues that a women go through in the menopause, both physiological as well as psychological as well as mental, and a lot of problem in the relationship as well as loneliness. Everything comes into her life. So how we are going to look into her way of this aspect of her life, that is very, very, very important when you look into the women's menopausal life. And we all know a woman, as she gets older, she has the physiological changes of the aging. Associated, she has an increased prevalence of medical disorders, which also has an impact on her sexuality. And also very important, this may cause a lot of problem in the sexual life. So we all know the normal aging also brings changes in the body, sometimes interfere with the ability to have and enjoy sex. As we age, our body changes, including the weight, shape, and the muscle tone, and also all the changes which happens, which make the partners feel uncomfortable, that they are not good in their bodies. They may start worrying that the partner will no longer, they become attractive to the partners. That is the one important they feel about their self-image when the body changes happens. And the health conditions, in addition, they cause a lot of physical problems, add on to the stress and worry, which may get into the way of the intimacy and make them difficult in enjoying the sex. And we all know that changes that occur because of the aging changes, what is the estrogen's main important in the women's life? It causes an atrophy of the vulval tissues, thinning of the skin, atrophy of the subcutaneous fat, and decreased hair growth, and atrophy of the vagina, making it very short and narrow, and also causes a constriction of the introitus. And this makes the vagina even tends to become very thinner, less elastic and smoother, and to make this decrease in the rugal folds also, which makes it very difficult for the penetrative sex to happen properly. And all the more, there is an atrophy of the estrogen dependent tissues in the pelvic floor muscle, especially around the urethra, uterus, ovaries, and causing a decreased vascularity, and the secretions causes a decrease. So all these things added to it, there is alteration in the glycogen in the vaginal epithelial cells, which results in the change of the pH of the vagina from the acidic to more of a basic and even a little alkaline. That makes the vagina thinner and stiffer with less lubrication, and that causes a lot of problem of the vaginal penetration and painful or less desirable way. So all these changes have a great impact not only on the sexual life, also causing a lot of incontinence, recurrent urinary infection, ultimately leading to many of the sexual dysfunction. So most of the time, the sexual act needs a lot of all this lubrication, all the stretchability, elasticity, which when lost, they go for a lot of problem related to the urinary infection, which may affect their sexual functions also. So the vaginal dryness as well as the vulvovaginal trauma and leading on to infection, everything becomes a vicious cycle, and that has a great impact on her sexuality. So the effects of aging definitely have a lot of create a major anxiety among the couple, but we need to have a proper education. If you do that, the sexuality can remain enjoyable throughout the life. There are a lot of misinformation about the sexuality among the elders, even among the young people. So that has to be corrected with a proper, adequate education. Of course, we all know the sexuality may have a lot of impact because of the disease they come across in the middle age and in the menopausal age, which can cause a lot of pain, disability, negative image, depression. All the things can cause a lowered libido, both in the men and the women. And men also go through the erectile dysfunction because of all these factors, causing a lot of effect on their sexuality. And all the more when they become older, if one of the partner becomes ill, and that will definitely have a major impact on the sexuality of the other partner. So they become the one, they have to take care of the other one. So they have a lot of problem related to the caretaking of the ill partner. So that also has a very great impact on their sexual desire and also about the sexual act. So they have to have a proper communication and understanding of the difficulties the other partner go through. So that is also a very important part in the sexuality. So when you look into the sexuality in this 40, there are a lot of impact of all these conditions, like the disease, the changes, the medical conditions, all the surgical procedures they go through, a lot of degenerative changes which happens in the bone and joint in the form of arthritis and susceptibility to infection, and a lot of medications they take for the illness, all have a major role in the sexuality of the elderly couple. So they always look, many a times when you look into the middle-aged couple, they always want their sexual activity to revert back to 20s and 30, and instead they find a lot of ways to optimize their response to the sexual experiences. Many times they may go for a satisfying and mutually acceptable, but many times because of all the disease and illness, they may have a little difficulty in this way. So it is our responsibility as a practitioners to know about the difficulties, put forth leading questions to the patients when they come at 40s, to ask about one simple question: how they are they happy about the sexual act, or are they happy sexually? If you put a question, definitely they will come out with lots and lots of answers, lots and lots of doubts. They will be opening a lot of information about their inner intimacy related problem, relationships, problem, sexuality problem, everything will come out. So we have to be educative to ask the simple question to every couple of us. Even in the developed countries, still talking about sex is still remaining a taboo, and all the more from our country, and where there is a definitely the questions, even in the general history, we never take about the question except for the infertile patient. Infertility patient, we never ask for the sexual history in the gynec patients or in any of your obstetric patient or even in any of the couple, except when they come for fertility, we ask the question about their sexual life. But we have to take a real concern to ask about every women who attends your clinic to talk about the sexuality, which is very important. And all the more, they need a lot of counseling related to sex when they do a hysterectomy, when they come across with an oncology, when they come with the diabetes, when they come a repeated genital infection. We should not only treat their infection, but we have to give a very important step of how they are going to tackle their sexuality, because many times that plays a very greater role in their quality of life and making them go for a lot of problem related to the marital issues and the partner disability, and many even in divorces, and a lot of second marriages and a lot of infidelities happen because of all these things which were not well discussed with a couple when they come across with some gynec or an obstetric problem. That's a very important one. So many times when you look into the elderly women, almost all the phases of their sexual function, the desire, arousal, orgasm, pain, everything is being affected, and almost all the sexual functions are affected in the elderly. It's all we know that it's mainly because of the physiological changes as well as the psychological difficulties, and also a lot of fear about the pain, discomfort, repeated infections, and also regarding the pain and almost not satisfying the husband. All these things play a role in their all the sexual functions being affected. So when you look into the sexual related complaints, which almost all the components of the sexual functions are affected in this women. So we all should be well versed in some way of treating this couple. So that is a very important one, because many times they have three important problems. One is they don't have a desire. They're not interested about the sex. Second, even if the other partner has the good desire, they're not cooperative. That's the problem they come across when you ask the questions as a couple. And secondly, they have the problem of, next is the pain. When they don't want to have a desire, their next step is the pain. they don't have, because they will have a pain, they will avoid sex. And third is the psychological aversion in the relationship. These are all the three important things that they come across when they come with a sexuality problem. But the very important thing that we can treat are through two things. One is the treatment for the desire disorders, and second, we can give for the pain during sex. So the treatment is mainly education, proper counseling, and second, some amount of a hormonal treatment, which could include a HRT as well as a testosterone. And we can suggest them certain couple related therapy with the form of a sex therapy, cognitive behavior therapy, and the psychodynamic therapy, and also the mindfulness techniques. So very importantly, we have to know as a gynecologist, because we work with these organs, the vulva, vagina, uterus, it's our organs. So we are responsible to know about what are the things that we are going to tell this women when she comes with the vulvovaginal atrophy. The important drug that we can suggest them is the low dose vaginal estrogen therapy, which gives them a very good improvement in the vulvovaginal atrophy. That can be given as a cream, or it can be given as a patches, or it can be given as a moisturizer, or it can be given as a lubricants. You should know the difference between moisturizer and lubricants. Moisturizer will keep the moisturize the area, but lubricants will have the effect of sustain, effect, which will have a very good improvement in the sexual, during the sexual act. They need more of a lubricants instead of the moisturizer. So these are all some important things that we should know when we come across a woman with a vaginal atrophy. Topical testosterone, yes, there are off-label use of topical testosterone. We give in the range of 300 micrograms as patches and creams, which can be used for giving for this desire disorder women, which will definitely improve their libido and the desire. And flibanserin is the only drug which is FDA approved. We all know it is a centrally acting, which acts on the 5-hydrotryptamine 2A antagonist, and also it has a more effect on the dopamine, increases the dopamine effect and norepinephrine, and reduces the effect of serotonin. That is how it acts, but it should be given very cautiously, because it has an effect on the blood pressure. So we have to give it very cautiously. So this is the main, at least we should know three important things: the moisturizer, you should know about the lubricants, and also we should know about the HRT. These are three important things as a gynecologist we must know when we come across any women at perimenopause and menopause. We must ask for the history, we must educate them, we must give them a solution for these problems. So many times the couple wants to have all these things, so you must know about their sexual functions. But when you look into the elders, almost in the menopausal, post-menopausal, they need more love, intimacy, affection, companionship, concern, mutual respect, understanding, and treatment of ailments. These are very important one, which a healthy sexuality has to be fulfilled. And we as a practitioners should know about all these things, to talk with them, educate them, counseling them, give them a good guidance. And they need a lot of family support. You have to talk with the family also to give them the support through the family, give them a privacy, give them a separate, don't separate them, because in this world, when we, when the children are in abroad, then the mother goes there and stay with the son for 6 months to take care of the children, and the husband stay here in other part of the world alone. And that part think that you should always think not to separate them, give them the privacy, give them a way to have their own life. That is a very important one. And also they will be helpful to maintain their companionship. That is also very, very important. So we all should know the awareness of the sexual need of the elderly people is an important quality of the life issue. So as a healthcare providers, we need to be open to discuss about the sexual need of the elderly people. Never stop your gynae consultation without a word of asking them how is their sexual life, which will definitely be a boon to you. And also they will be very happy to talk with you and provide the treatment which is very appropriate. Educate them about the awareness about the sexuality and their needs, and ask them to have a good communication. Try to make them stay close to each other, make them make a best way of relaxing in the presence of the partners, and their desired differences has to be taken into consideration. You have to talk and counsel with them separately, ask about the level of the desire, because that may have an impact on the relationship. make them to talk about it, and thereby try to make the partner understand and make them supportive to satisfy their needs. And very important, we should know that the sexual dysfunction still is highly prevalent. Though we may think that the elderly people stop being active in sexually, but still they continue their sexual act till the last day of their life. So always keep this in mind, ask them, because they may have a lot of dysfunction, try to correct them, which will give them a good emotional and physical support, and also help them to correct their problem, which may help to improve their systemic and the quality of life too. A very important one is the sensitivity of the physician in approaching the problem is very important. And we should have a sympathetic approach along with a relevant treatment to these women will go a long way in improving the symptoms. So we all should address the physical and the psychological and the couple factors involved in the mature women, the sexual concern. The physician play a very major role in helping the patients to have an improvement in their sexual function, and thereby that increases their self-esteem too. Thank you so much for the patient listening, and I'm open to questions.
Thank you, ma'am. Over to you, chairpersons.
Thank you so much, ma'am, for touching the very sensitive part of a woman's life at 40. I'm wondering, in the meantime, Dr. Kiran sends its regards to you, ma'am.
Yeah.
We have met
So
for the first time, though on this webinar. Dr.
Yeah.
Kiran keeps on saying many good things about you all the time.
I know your Pune is so, I'm so close to Pune. Every event in Pune, almost 90% I'm an invited faculty there. I mean, convey my wishes to Dr. Kiran too. They were all very much supportive and encouraging to us. And thank you. And I need all
I have only one question. I'm wondering how many times should we send these people for psychological counseling to a specialist or the expert?
See, you are the specialist of the organ which deals with sex.
Yeah.
So you must see there are three components. One is the physical, the second is the psychological, third is the relationship. Those three are the main important thing we have to look into it. So we need a counseling. You are the good counselor. You talk with them because you will be the obstetrician for them, and you would have been the gynecologist who would have done many things for them. So take the confidence of the women and talk with her. And you can definitely look into all the psychological aspects of how their relationship, how their personal understanding, how their communication, how their expectations in the sexuality, all these things you can yourself talk. You have to give some time, some time in your gynec basic practice to some time to sit with them, talk with them. If you take one couple of you to talk for a half an hour for one consultation, you can definitely cater 30 couple like them, so that they will give confidence in you. They don't need any psychological counseling. Psychologists, they never give. They see the practical reality and give them the support. Ultimately, it is you that you're going to look into their real problem, because if she has an atrophic vagina, whatever you give her, do a caressing or your non-penetrative sex, still she won't have any orgasm or she won't have any comfortable in the penetrative sex. So if you correct her problem, give her a good vaginal lubrication, that will help her to improve in her quality of the sex. So the counseling plays one role to find out what the problem is. Is it a problem with the physiological or the psychological? But you can yourself do a very good job when you sit with them, talk with them, get the reality of the sexual difficulties. That will help them to correct the problem in the best way.
Thank you so much.
Madam Jairani, that was a wonderful talk you've given here. I'm Dr. Asmita. I'm from Chandigarh.
Yeah, nice.
I must say that you've touched the topic so beautifully that this has a component. And when I started this menopausal clinic dealing with women with this kind of issues in this part of India, this is a very male-dominated area. I'm sitting here, ma'am. And when I started speaking to the patients one-to-one and as a couple, I realized because of that male dominance, the desire of a man is totally different from what a woman is going through. And as you rightly said, there are three components to the problem. One being a physical changes, what as a couple, as a man and a woman, they are going through. It is not only a woman who's aging, a man is also aging equally.
Yeah.
And at the same time, what they imagine is what they did 20 years ago. So we have to correct their approach, telling them, yes, life has changed and probably your expectations from your sexual partner and your way of achieving that desire should also change. And it has really helped those people. little amount of medication, lot of talking. As you rightly said, half an hour spending with them probably tells us so many things, that how they eat and how they sleep.
Yeah.
Thank you so much.
Thank you so much, ma'am.
So nice. I would like to put only one word. We should open the question. That is very important one. And secondly, we all should, we should give the empathetic feeling for the women, that sometimes they may feel very difficult to talk with us. So we must give them an empathy to talk with them. That will make them more confident, and that will make them more happy about everything in the life, because they feel a lot
Very
of doubts and difficulties. That is a very important thing. Many women go through depression at that age. So if we give them the positive confidence and give them a good solution, they'll be very happy to go through the sexuality in the old age.
Plus, in our society, probably the women don't have that kind of approach, and they don't have that kind of social circle where they can open up and discuss their problems.
True. That's very, very true, because the most important thing is gaining their trust and confidence. Once we gain the trust and confidence, they'll be able to open up and talk at length about this, because this is the inhibition that they have got, that, okay, fine, at the same, it will be like this only. Why, maybe my, I can't discuss with my mother, I can't discuss with my sister. So everybody seems to be doing the same thing. They assume that everybody goes does not have sex after the age of 40. Then when people ask, I tell them, no, there is no age bar for sex. So,
Correct.
So I think, thank you so much,
So
ma'am.
I just want to make one last request to all here. One is from North, she's from Punjab, and one from Pune. Kindly support me in my Foxy election as the Sexual Health Committee chairperson, because I'm contesting for the second time. First time I lost. I had the passion of doing some good work for the sexual health. So you all should tell your president and secretaries of your Foxy societies to support me, to nominate me, and put their vote for me.
Sure,
It's a
ma'am.
humble
Definitely
request.
check for you,
Please
ma'am.
do the campaign for me.
All the best.
Sure. Definitely.
Thank you.
Thank you so much, Karpagammal, for giving us the opportunity.
Thank you. I'll just
Share
give the
this
vote of
esteemed
thanks.
panel.
Yeah. Thank you so much. Thanks for joining, sparing your time. Now, I'll give the vote of thanks because Dr. Deepa is unable to join because of a condolence to the family and she's traveling. Wholeheartedly, I thank everybody from President Madam Jairani Madam. She was, when I was talking, Madam, I want to talk about fertility at 40, then something else about POA, then I want to talk about, Madam said, Madam, you took she volunteered to talk about sexuality at 40, and I said, you will do the best justice for this topic. And Madam is so passionate about it, and she has done complete justice to the topic given to her. And thank you so much, the other speakers also. Chairpersons, Dr. Asmita, when I just asked, she said, fine, I'll definitely be there. And Dr. Shubha Lakshmi, thank you so much for sparing your time. Thank you so much. And it's Shiva Lakshmi is my Mediscan friend, so actually our friendship dates back to almost 15-18 years.
Yeah, 2005.
Yeah, 2005 we did Mediscan training. Thank you so much, Shiva Lakshmi. And the speakers, amazing job done by all the speakers. Sushila ma'am on POI, it was like more like, I just said there are so many types of POI where we really have to learn a lot about it, and management strategies. Then Divishri is a fertility expert, so she gave us in-depth side about fertility at 40. And Madam was like really superb presentation and superb talk about sexual health. And I think we all of us, we have to understand the differences. As I said, the differences of opinion, even that relationship component also actually has a role to play, the psychological and the physical. Thank you so much for enlightening us about these things. And I thank Shield for giving us the platform for this midlife committee webinars month after month. And I really enjoy doing this presentation, preparing for it, talking to people, communication. And thank you, Madam, for giving this opportunity.
Thank you.
Definitely we'll see you next time. Thank you so much.
Okay, bye. Thank you.
Bye.
All.
Good night.
Bye. See you all again.
Bye.
Thank you all.
Bye.
Thank you. Bye.
Bye.
Bye.